like me to lift the conversation higher.
Good evening and welcome to the Concord Alumni Chapter of Delta Sigma Theta Sorority Incorporated, Black Maternal Health Fireside Chat. My name is Dr. Dezette Johnson, and it gives me a great pleasure to be a part of this heartwarming, heart-fulfilling fireside chat tonight. We have extreme guest of panelists, and it's my honor to introduce them to you. First, I would like to introduce Dr. Gail Griffin. She is a board-certified OBGYN who brings warmth, empathy, and expertise to her patients. She is passionate about supporting women through every stage of life, from adolescence and reproductive health to menopause and beyond. Our second panelist is Dr. Malu Freeman Kawaku. She's a board-certified OBGYN. She received her medical degree from the University of Virginia School of Medicine and has been in practice for more than 20 years. She enjoys getting to know her patients very well and feels it's important to consider the whole woman when evaluating their healthcare needs. Stacy J. Marceline is a licensed clinical social worker, international board-certified lactation consultant, and maternal mental health specialist with over 20 years of experience supporting women and families across seasons of transition, healing, and growth. Our last panelist is Robin Price. She is a compassionate and experienced labor doula and childbirth educator. She is dedicated to offering holistic and empowering care to birthing individuals and families with an empathetic and deep understanding of the unique needs of Black and Brown women, including those navigating infertility and prior pregnancy loss. Robin's mission is to create a safe, nurturing, and supportive space where families feel informed, respected, and empowered throughout their birth journey. I will now turn it over to our mistress of ceremony, Miss Sarah Lowry.
Thank you, and thank you all for being here. We're really excited to have this conversation. We're going to have this conversation on Black maternal health from different lenses, whether it's clinical, emotional, or from an advocacy lens. So we're going to have this conversation like we're sitting in someone's living room, very, very casual. And so before we get into solutions, we want to talk about what's underneath all of this. We know the statistic that Black women are 3 to 4 times more likely to die from pregnancy-related causes. And that gap does not close when it comes to income or education. So this question is for the entire panel. When you look at our community, what are the most overlooked or misunderstood factors that are driving these disparities? And we can start with Dr. Griffin.
One of the things I would say is, in terms of disparity, I think that we can sometimes all be lumped under, it all boils down to a lot of, a bias in terms of what they think we are as Black people or Black women in general. Throughout my years, I've always liked to try to individualize everybody, taking in point your individual history, your past pregnancies, medical history, all those kinds of things. But I think when it comes to some of these grave errors that are happening to us when it comes to deliveries and poor maternal and obstetrical outcomes, it basically boils down to bias, and we are not being paid attention to in the ways that we should have. I think we are all looked as inferior, as hard as this sounds. I think we're looked at inferiorly, and we are not taken seriously. And despite efforts that they have tried in recent years, unfortunately, with the current administration, I think some of these things are being taken down presently and into the future. So I think it's going to take all of us and many forces in the healthcare field to eradicate some of this.
Thank you. Dr. Freeman?
Good evening. I was going to say good morning. I also agree with Dr. Griffin and everything that she said. And, my first reaction, hearing the question and even hearing what she's saying and just knowing what's happening is just to almost feel despair, because I think that things were sort of going in a certain direction before any of this new efforts to try to, I don't know what I would even call what the efforts are to discriminate, to um, marginalize, to eradicate Black excellence in so many different career fields. Um, I think now that that's happened or is happening, it almost makes it even more of a hill to climb up. But I think, in agreeing with Dr. Griffin, I think that we have to continue to work hard through that. We have to continue to encourage Black and Brown people to enter all fields that will allow us to make a difference and make a change and not be discouraged by what's happening now. And I know it's easy for our young people to be discouraged, but just to kind of keep on moving forward and to continue to demand excellence, even in an environment where it doesn't seem like it's appreciated or desired, really, because I think they know that when you don't get involved, and that's when, things happen. And it's obvious that there are certain groups that don't care about others. So we just have to continue to push through.
Thank you. Ms. Marcelin?
I agree with Dr. Griffin and Dr. Freeman. Their thoughts encapsulate a lot of the issues that we're seeing, issues with implicit provider bias and career-wise, the how the current administration is really shifting away from prioritizing maternal health and infant equity. So it's multifactorial. And there's just also that disregard for patient concerns, and sometimes there's disrespectful care. So I think what we're seeing is is coming from a lot of different causes. We can even look at differences in our healthcare coverage, and we can compare that with one another. So there are a lot of areas for us to work on and unroot those the impact of those things, those factors.
Thank you. And Ms. Price?
So definitely aligning with what others have said, but bringing the non-clinical lens here. I think one of the things that gets missed is that maternal care is not limited to just the clinical view. So thinking through the component and the fact that maternal outcomes, it should be addressed from the lens that it's more than just the day that you give birth. It's more than just that series of time. It starts prior, it starts outside. And so I think one of the things that, aside from the obvious racial disparities, racial bias that we see, the lack of care and even the system even trying to account for that, it is that birth in itself holistically, maternal care in itself holistically is categorized in a simple bucket of a medical diagnosis and condition. And we have to step outside of that and realize that there are all of these external factors that contribute even before the day of birth. And that those maternal biases start often sometimes even before someone's even pregnant. And then they then extend even after the delivery. And so I think that for me is one of the things where we don't look at it. And I think Dr. Griffin said this holistically. We don't look at it as from an individualized perspective, even with providers and support teams that look like us. Is we have literally drilled maternal care to just the day you have a baby, as if it's that simple.
Thank you. And then, so building on this idea of bias and even looking at it from outside of a clinical lens, these next set of questions, I want to talk to those who are in the room during the pregnancy and birth. So for the providers, the doulas, and the support teams. So first to Dr. Griffin and Dr. Freeman, from your side of the table, how are you working to identify and interrupt implicit bias, both in your own practice and among your colleagues?
Ooh. Well, to be honest with you, I'm on the eve of my 60th birthday. I don't know about Mala, but I haven't delivered a baby in about, I guess it's been about 7 years now. However, in my current practice, I still do take care of women who are pregnant, and then when they are, have any issue or about to go into labor, we just send them to labor and delivery. One of the things I think that shapes me is that I have personally been a victim of this myself. And I keep thinking back, in preparation for this, I wasn't really trying to think about like statistics and things like this because I know we all know them. But with all of these recent tragedies that have happened with, women who are, ICU physicians and midwives and in, dying in childbirth, I think sometimes, well, that's something that could have happened to me if I didn't speak up. So I'm not trying to shift what you're asking, but I think one thing that I think that healthcare organizations are trying to do, which I know I do from the get-go, is to try to identify problems that we think can happen, that eventually will happen based on either, you know, risk factors, age, previous pregnancies. You got to think of that at the first visit. The other thing is, I think one thing I can say in contrast to, I have one practice I work for is all Latino people. And then there's definitely a dichotomy in women who seek care just to know what their issues are before they're going to get pregnant. I don't see that, I see that a lot with Caucasian women. I'm seeing that more with African American women, which I'm really pleased to say. It's kind of 50-50 with the Latino population. But I think that and speaking to Robin's point, it is important to identify some of these factors beforehand, like way beforehand. And also to have the conversations, but also sometimes time does not allow for that, unfortunately. So I know I'm kind of all over the place, but it really has been a minute since I've been freaked out in the delivery room. So I'll I'll ask for Mala's comment now.
I think I can combine your comment with, I'm sorry, our doula expert here is
Robin Price.
Mm-hmm.
Can you hear me now? I think the key is in the relationship. And I think that's one thing that we always really focused on in our practice. I also have a gynecology only practice, and I have a gynecology only practice, but I also do weekend travel medicine where I do obstetrical delivery. And, one thing I can say that in my practice, when we did have maternity patients, is our specialty almost out of it really wasn't intentionally, but we used to have pretty much our own patients. We'd share them amongst each other, a couple of visits, they would meet the other providers. But we really enjoyed getting to know our patients. And I think that that was key. And I think that's one of the important things that doulas are able to do is stand in that gap for some providers who, for instance, may be in a large group and just constantly rotate the patient around. There's no way that you can really, I just don't feel, give really good care because the essential part of the essential ingredient is really knowing the patient, being able to look at someone and say, she didn't look like that last week, or she's complaining more than she usually does. And being able to understand that those are important cues that a lot of practitioners miss. And so I don't think it necessarily is always just in the delivery room. It starts before you are in the delivery room. And just to add another second note, I think it's what's really important is having providers that understand the cultures that the patients come from, whether it's, African American doctors or Hispanic doctors or Asian, you can understand people's culture even if you're not part of that culture. And I think that's where there are a lot of problems that people just, if you have a diabetic, for instance, knowing that in this person's culture, they eat a lot of rice or beans or tortillas, and if this person's African, they're probably eating a lot of rice and fufu and other things that are starchy. So when you try to put them on a diet, for instance, that you'd give to a white woman, it's just not going to work, and they're not going to really understand what you're trying to say. So that is why representation matters. And it's also why having practitioners in a community that know that community or part of that community make the community's medical care so much better.
Thank
I
you.
just want to add, like, one thing I just want to add is, speaking to Dr. Freeman's point is, we just want to be seen. And that's what it really boils down to, because I know there are times where sometimes patients just feel like they're just, whisked away, or any concerns are not validated. And with what Dr. Freeman said, another word that came into mind is that continuity. And where, when it is a big practice, although it might be easier for the providers in the practice, it really does not serve best for the patient. So I just wanted to add that point. But good points from Dr. Freeman.
Thank you. And then Ms. Price, so as a doula, they're known to reduce unnecessary interventions and help families feel heard. So what strategies do you use when a patient feels ignored or dismissed by medical staff?
So for me, one of my approaches is I actually get ahead of it. So I think one of the reoccurring themes that you're hearing is not waiting until the day of birth. So I first make sure that I have a very honest, transparent conversation with my clients about who is your provider? Where are you expecting to have your baby? Do you only know one of the providers? So to Dr. Freeman's point, Dr. Griffin's point, like there is a rotation that I think a lot of clients are taken aback on, where it's like, you don't know unless you're having a C-section, you don't know who's going to deliver. And so all of the providers are kind of trying to touch and introduce. And so it's introducing my clients to what the process is, what the policies are, what this will feel and look like, and then identifying some of their concerns to those very scenarios. So that way, then I am prepared on knowing how best to support them with the intent that they will be empowered to sort of speak up for themselves. I am a doula that I don't believe I advocate for. I believe that I support in their advocacy of themselves. And so how we do that is I get to know their providers, so that way I understand what the provider's concern is. I make sure that my clients, I don't like to at all make the clients feel like it's my opinion versus the doctor. No, we are all collectively supporting and providing your care. Because to say it bluntly, I'm not a doctor. I can't deliver your baby if something goes wrong. And so for me, it's whenever we are encountering scenarios where it feels like there is a bias that is being presented, is making sure that my clients know that you do have bodily autonomy. You do have the right to say no. You do have a right to say, I want another provider. That one is not respecting or listening to me. And then so it may be something in one of the more extreme scenarios of working with the charge nurse to get another nurse, working with and requesting, can we have the other midwife or OBGYN on call? But that's actually very rare. And maybe that's unique to me because of the approach that I take to try to work with the care team rather than working outside of them. And so that way my clients know ahead of time, they have a game plan, and we talk through pivots, we talk through different scenarios. So that way that reduces the feeling of trauma of in the moment. If you do have to pivot on your birth plan, it being a shock value. So for me, it's very much a proactive conversation. It's very much a proactive collaboration with the care team. So that way we're not waiting until the day when I want them to focus on birth. I want them to get into their zone of labor. We're not having to play the politics bias game.
Thank you. And so we now want to shift into the emotional side of this because birth isn't just physical, it can be deeply mental and spiritual as well. So, Ms. Marcelin, we know 30 to 44% of Black women experience postpartum depressive symptoms, yet they're less likely to receive treatment. So, from your perspective, what cultural barriers keep Black women from accessing mental health care, and how do we break these down?
Well, as you know, we can't overlook the historical harm that has been done in Black communities. When we look back on studies like the Tuskegee syphilis study and even systemic sterilization here in North Carolina, but also present day experiences that we hear about from even our celebrities like Serena Williams. So that is sometimes in the back of our head, the distrust of a medical system that hasn't always taken care of our bodies. And there's also the strong Black woman trope that we sometimes buy into. And although it kind of reflects some resiliency, it can make it harder for us to prioritize our vulnerability and seek support. So that kind of keeps us culturally from accessing care. Um, Also, sometimes in our communities, we allow our families or our faith communities to try to manage our mental health concerns. And, this can also be a strength sometimes, but it also can kind of delay that connection to clinical care that we need. Um, so it's important to have those sisters on our side that, are going to be recommending you and recommending, supporting, and even going with you as you try to access that type of care. But I also want to talk about the psychological and psychosocial perspective because we have to consider the impact of chronic stress in our real life experience. Sometimes over time, we can begin to see our stress level. We can normalize it and think that, oh, this is how things go. This is my life. But that friend who tells you you're doing too much, they're telling the truth. You're probably doing too much. If that's someone that you can trust, right? Because we think, oh, this is what I'm supposed to do. I'm supposed to go take my kid here, there, and everywhere, and I'm supposed to be taking care of this person, and I don't ask for help. So we have to kind of realize that chronic stress is is impacting our lives and how it is impacting our lives. And finally, some of the other barriers that impact our care is just those structural barriers, um, barriers to culturally responsive providers, like Dr. Mala said, insurance challenges, and then there's our practical challenges like childcare and having time, and our work schedules. Um, so those are some of the things that we see, but we can overcome them by just kind of providing collective support, establishing agencies that provide like wraparound services that might provide childcare, or might provide other supports all in one setting, like access to food or housing support. Um, those are some of the ways that we can overcome it, but just kind of normalizing the fact that we all need help sometimes. We all need help sometimes, and we get by with a little help from our community. And that's kind of like going back to how we have traditionally been. And if you are feeling mistrust, take someone with you, take an advocate with you, take a friend with you. So those are some of the things we can do to kind of overcome those barriers.
Thank you. And kind of going along these lines, I want to talk about that fourth trimester because birth doesn't end when the baby arrives, right? And so these next set of questions will be for everyone on the panel, and it's going to be kind of a two-part, so you can answer the one that you feel most comfortable with. But what does a supportive, culturally competent postpartum plan look like for Black mothers? So what should be in place? And then what are some of the postpartum warning signs that Black women are often told to ignore, but absolutely should not ignore? And so we can start with Dr. Griffin.
Pardon me, I stepped out to get my other phone as the doctor called about my daughter, but your first part of the question was, please remind me of that, but the
Yeah,
second
no, I
part
can
was
repeat the
some of the
question.
warning signs?
I
I'm
can repeat it,
sorry,
no
I'm
problem.
sorry.
So the first part of the question is, what does a supportive, culturally competent postpartum plan look like for Black mothers? What should be in place? And then what are some of the warning signs that Black women are often told to ignore that they absolutely should not ignore during postpartum?
Okay, I'll tackle what I can, and then whatever I omit, Dr. Freeman will probably pick up. In terms of postpartum plan, I think that is mostly based on pre-existing conditions, and also secondary to that, like any issues that might have come up during the delivery. So for instance, if a mom has hypertension, high blood pressure beforehand, or if she had a complicated delivery or a difficult C-section with some signs of infection, there are typically reasons for her to come back into the office well before that quote unquote normal 6-week postpartum check. And there may be some other things that I'm omitting, but it's based on pre-existing conditions that need to be followed up at, like if a woman is on insulin for diabetes or gestational diabetes or pre-existing diabetes, a lot of those doses have to be altered and lowered after baby is out because you're delivering for 1 instead of 2. In terms of the postpartum plan or the follow-up or the warning signs, this is where I think this implicit bias really comes out, because when we complain or when we make these complaints and call and say, oh, I have a headache, or let me just go back to the signs really. Headache is major one. Swelling, extreme swelling in the hands and feet both of those can be a sign of postpartum preeclampsia or preeclampsia that was diagnosed and didn't really go away with the treatment. Infection is another one, heavy bleeding, usually more than a pad an hour, fever, and pain that is outside of the ordinary and not responding to typical medication. But in some of these tragedies that I have seen, it's these everyday kind of warning signs that are bread and butter for obstetricians that I feel that when I've learned of these situations were completely ignored in these situations of some of these moms that lost their lives. Next time, Dr. Freeman, go first.
I got you. Well, Dr. Freeman.
I think she covered it. She covered it very well. I think one thing I wanted to mention that had to do with the first question prior to you getting to this question that you asked Dr. Griffin is one thing I think has been very helpful is having an objective way to measure how a woman is feeling postpartum. And with the new, what is it, PHQ?
PHQ-9?
PHQ-9, I don't give it. So PHQ-9 to make sure that you're kind of looking objectively at what kind of and then being able to talk to the patient about if her score is very high, like what does that mean? Because it's an objective measure. Now when you go to your doctor or your gynecologist, we do it in our office, and some other specialties may do it, the depression scale. And it gives you an opportunity to stop and say, your depression scale scored a little high. Do you feel that you're having some issues with, coping or depression or whatever term you want to use with that particular patient? And I think that's been very helpful. The other thing I would say is that postpartum depression or even depression, anxiety can often look a lot different in Black women. And sometimes it comes off as just anger. And then we're always the angry Black woman. But sometimes the anger is magnified because the depression is magnified, because there is a certain level of stress that I think we carry as Black women that, may be portrayed differently in different people. But when you magnify that with something that's going on that causes, depression, it can be even more magnified. And that can be missed. You can just think that, oh, she's just angry at something, when in reality, she's very depressed. So it's important to acknowledge that and address that and to see that. And if your perception is that Black women are always angry, that's something that you're definitely going to miss. So what does it look like postpartum? As far as having resources, obviously seeing your provider, having that PHQ-9 objectively looked at. I think one of the hardest things we face as doctors is just having people to refer someone to. And we can always, put someone on medication if medication is indicated, but it's really important to have someone that person can talk to be able to objectively talk about what they're feeling and have objective strategies about what they can do to make, to reduce some of their anxiety or to help them with some of their depression. And sometimes it's just very difficult to find that. And our family can sometimes not be the best at helping us with that because they're giving us their side of things and what we should or shouldn't do. And then that's sometimes how things can go missed or untreated.
And I kind of want to piggyback off of that too,
Perfect.
Dr. Lowry, just that the Edinburgh postpartum depression screening that Dr. Mala is talking about is administered at pediatrician appointments. So when you take your baby back, as well as OBGYNs, we're administering it at Novant through our nurses and lactation consultants. But what I'm finding is that sometimes the patients don't know what their score was, or they don't know whatever became of that survey, right? So we have to encourage our loved ones to ask about it. Or, when we go there with them, we say, how did she do on that? Because as a person who's struggling, you might not, even mention it. You're just kind of going through the motions.
Mm-hmm.
So kind of like being aware that that is something that your provider should do, and kind of finding out how you did on that can be helpful in helping you to seek help. And also seeking specialists. I am a maternal mental health specialist. And so finding those providers that specialize in the care of women struggling with perinatal mood and anxiety disorders is important as well, because they have that special training to be able to help you more effectively. That's kind of what I wanted to add. And doulas are also offering the EPDS as well. So, we can all do this together, but reminding our loved ones like, oh, how did you do on that? Did you do that? Did they offer that to you? Kind of finding the gaps that are not occurring.
And Ms. Parsi, you have anything to add?
Yeah, I'll jump right in. I think it is first, I know with my clients, we develop a postpartum plan. So having a postpartum plan, not just a birth plan, not just a labor plan. Like, what are you going to do when you bring this baby home? like how are you going to support? And then having a plan after your support then leaves, which I think is a big thing that a lot of people don't prepare for. Grandma comes in, mom comes in, friends come in, and everyone's excited when the baby's first born. But then what happens after those first 2 weeks? And then that support starts to kind of wear off. So then what are you doing? And then that's where mom and dad start to really feel overwhelmed. So oftentimes we actually spend time talking about what that support plan looks like. Do you actually need the support right after you have the baby, or do you need the support a few weeks from there? So being a little more strategic and organizing the postpartum support. Another thing too, in addition to the survey, we talk about what does postpartum depression look like and how is that different than the baby blues? And this is where I really lean into the partners and making sure that the partners are aware, that the family is aware, because culturally we are what Stacia said, we just are okay with just going. We have normalized being overwhelmed. We have normalized being stressed, and that on top of one of the most significant, overwhelming hormonal shifts of your life in a very short period of time is not normal. It is not normal to be overwhelmed on top of being overwhelmed.
Mhm.
So we talk about intentionally what mom might look like and feel like postpartum, and how her new norm is going to shift for an extended period of time, and emphasizing postpartum can last up to 2 years, and for some people even longer. So it's also not when you get to, like Dr. Griffin and Dr. Freeman said, at your 6-week appointment, and then I'm okay, I'm out of it. So we talked through that. And then one of the things that I know I always like to do, especially if someone has a pivot in their birth plan, is not dismissing your feelings by saying, oh, I had a healthy baby and I'm alive. Like, it is very disheartening to me that women, particularly women of color, are criminalized and made to feel guilty when they have a feeling and emotion about disappointment. And I always say two things can be true. You can like that, you can not like that something happened and still love and be excited about having this baby. You can be overwhelmed and be like, I don't want to be a mom in this moment because I'm sleep deprived, and that not mean that you aren't happy about having a baby. And so making sure that the partners are prepared for mom to be extremely overwhelmed and maybe even distant when after having this baby, and not shoot her down or dismiss her feelings with, yeah, but baby was safe, and baby's here and you have a baby, and recognizing that those two emotions can be true. And then also making sure that the partners recognize you can have postpartum depression too. And it's not just the mom, and that their postpartum depression looks different. And I think that conversation's not had enough. And I think we're scared to have it sometimes because we put so much focus on the birthing person and mom having the baby, that we don't realize if partner is feeling incapable or inadequate, that impacts the very support that mom needs. And then that can then start to attribute to mom sort of feeling overwhelmed, and mom then stepping. So now you have two people in a postpartum depression state, and it just kind of continues to spiral. So I think it's having a plan. I think it's talking about it before you have the baby. And I think it's recognizing that how it shows up, and being open to and not dismissive of the whole family, not dismissive of mom being overwhelmed and chopping it up to, you just had a baby, you're going to be tired. So.
Thank you. And you kind of led me into my next question before we open it up to the audience. And so this is open to everyone. What role does the wider community, which could include partners, family, and friends, play in making sure that the mother has a safe and empowering experience? And so I'm going to start with Ms. Marcelin this time. I saw your comment in the chat. You want to build on that?
Oh yes. I was just saying in my comment that we have to kind of raise the expectation, like Robin said, like baseline, we are supposed to come out of a delivery alive, and we're supposed to have a healthy baby. And yes, it's a blessing when that happens, but let's expect that, let's expect that of our healthcare system. Um, but also, I think as a community, we can support one another. We can educate ourselves. Like Robin said, we can pass along information so that fathers know, that the family knows, and we can also share our experiences. Because a lot of us have been through something similar. A lot of us have suffered from preeclampsia or a high-risk pregnancy or postpartum depression. And so if we can be vulnerable and share our experiences and normalize it, like, yeah, that happened to me, or talk to our daughters or our nieces about our own experience and be willing to share that, that can help normalize the fact that we need support and we are a community and we're here for each other.
Mm-hmm. Dr. Freeman?
I'm always agreeing with everyone. I agree with Dr. Was it Marcelin? Dr. Marcelin? Just
Stacey.
saying. I don't know if I have anything else to add to that. I was sitting here thinking, Robin, as you were speaking, that I wish that I could turn back the clock, because it would be wonderful to have had a doula in our practice, because it just rounds out the care. And I have to be honest, some of my interactions have not been as positive because I think that sometimes we get in these, we get in our little pockets, but it's so important that women receive this well-rounded care. And I guess they're trying to do that more now with sort of more group meetings and that I think that that's also really important. And I sort of missed my window on those things, but I can still focus on having the healthy babies at the end and having a good experience for the patients that I do deliver who don't know me when I walk in.
And Dr. Griffin, you might be muted. No. I'll see if Robin, if you had anything else to add while she figures out her sound.
Yeah, I'll say just briefly, not limiting who supports you. So I know for me, I am such a pro advocate for dads. They are left out and they are excluded so commonly. And I think if we lean into them more and give them space to show up, give them space to advocate for their partners, answer the questions that they have, that right there, I think is a missed opportunity to start to influence some of these despairingly outcomes that we're seeing. Because what's happening is that dad is excluded the whole entire time until something goes wrong. And then you're expecting him to then make a decision. And no one has educated, informed, supported him that he's then already at a vulnerable state. And so I think that that's a missed opportunity that when we think about community, that we should not exclude the partners. Like I think yes, our moms, our sisters, our friends, are amazing supports, but Stacey, you said something else that it's like they may be coming with their own trauma, and that your birth might be triggering them, and so that may not be the best person that is equipped to support you in that moment. Why not lean into your partner and make sure that he is there to be able to see some of those things? So I think that is another missed opportunity to engage our men and allow them to carry us a little more through this journey, because we aren't by ourselves. And I think that's sometimes where I hate to say it, but I will, we sometimes give ammo for some of the very stereotypes that we are faced with. The independent, strong woman, I can do it by myself, and not giving space to welcome our men in to help carry the armor. And frankly, they are part of the reason why you're pregnant in the situation anyway. So include them in the journey from start to finish. And I think that will make more of a difference than we probably give credit for. So that's what I'll say about that.
Great point. Dr. Griffin, do we want to try? No. If you put something in the chat, I will read it off for you. Okay.
Dr. Larry, I just kind of wanted to add real
Yes.
fast. I love what Robin said, because I was in a birth recently and I saw the father stand up for his wife. He said, just give her one more minute, or just, can you allow us to have another minute? And he asked excellent questions. And then as we processed afterward, he did have his own experiences. He did fear for his wife's life. So it's like we do have to include them in all aspects of the pregnancy, not just those prenatal appointments, but in all parts. And they are going to show up. They're absolutely going to show up. And the other thing I wanted to add was just political action that we can take as a sisterhood, try to be aware of current legislation that's going through, and let's activate ourselves. There's organizations like Postpartum Support International and momsrising.org that are out there lobbying for us, so if we can get involved as a community in those type of endeavors, we can have an impact as well.
Thank you. And before we open up for questions, I see Dr. Griffin's comment in the chat. So she said, this reminds me of something that Novant used to stress. Ask me 3. Bring a list of your questions and make sure you get them answered. And so that's another way that women can advocate for themselves and the community can help them as well. Okay, so we want to move now into a time of questions for the audience. And so if you're joining us live, please drop them in the chat, anything that you're curious about. Feel free, how want clarity on, or you want them to speak a little more deeply on. And so we'll take a few minutes to have those questions come in.
Chantel, we do have one question that was already put in there.
Okay, great.
It says, do you all find that it creates more tension if the patient requests another provider when trying to advocate for themselves?
I can take this one because I've had experience with clients requesting another provider, be it a nurse is probably most common, but I have had instances where we did have to request a physician. And I think knowing who your care team is, because although I am a doula, you got to check out your doulas first. Just like to Dr. Freeman's point, I'm sure there was some bad experiences. You got to check out your doulas no differently than you check out your physicians and your OBs. And so I think for me, in my experience, we've been successful at navigating those instances where we did request a change because I take that into account in how that situation is addressed. Meaning, I ask my client, do they want to make the request? Because I don't ever take the position to just speak up and say we need someone else. Before they do that, I try to get them to kind of explain what is it? Is it they're not reading the room, right? They're not listening to you, but it doesn't have anything to do with the quality of care. And I think that making that distinction is very important. Not that it differs in requesting a change, but it differs in the type of change that needs to happen. Meaning, I've never had an instance where we requested a provider change because care was not being provided safely or according to appropriate protocols. It was cultural bias. It was they didn't know how to read the room. They weren't listening to the client. And so that's where I got that confirmation from my client and was very strategic in sort of talking to the charge nurse or to the doctor that was on there. And first, for me, my approach is always leading with this is not a quality of care physically or clinically, but this is an experience that is impacting how the client is experiencing. And I think that that has been helpful, at least in my experience, in preventing my clients from getting any sort of blowback from requesting a change. And I think that that nuance is always important to matter, because if they're providing bad care that is unsafe, it's unquestionable that someone else needs to come in. But if it's a cultural thing, that has to be navigated a little differently.
And this is what I wanted to speak to before. Can you hear me now?
Yes.
Okay, good.
Yes,
One of the things that I was trying to address in my chat, I think that when it escalates to a level where somebody actually is, where it's that tense and that, kind of angry in the delivery room, when it's supposed to be a really relaxing and happy and, painful, but, happy time, when it escalates to that point, I think that when people are fearful and they don't understand what's going on, that's where the anger comes out, especially in people that look like us. And if you look at us the wrong kind of way or something's kind of side-eyed, sometimes it just can take off in a different direction. So this is where I think really, really understanding what is going on, why the doctor is saying what he or she needs to say. And I think that this is where the rubber meets the road, where the doctor needs to sit down and, like, even if it's 30 seconds, explaining to mom and dad, family, whoever's around, exactly what's going on, what we feel is happening from our standpoint. If you just rush in and say, oh, if it's emergent and truly emergent, then we can we can get that point across. But when there's time to spend a minute to really explain what's going on, it can allay that fear and decrease all the tension and anger and, like, what is he talking about? That kind of thing. I just think communication is really, really important. And it has to come from everybody. You know, there's nothing like, I know we've all experienced it, where you just get that look from somebody and you know they're just not right. And you know, and then especially when you're about to deliver, you know, when you're there, when it's supposed to be a happy occasion and you don't feel like the nurse taking care of you is not on your side. And this is feedback. Every single patient that I had at my most recent practice, when they have delivered at both of the hospital systems, I was like, how did it go? You know, if they would go into triage, how did it go? How were you treated? And, you know, I got mostly positives and some negatives. And when I got negative feedback, I reached out to the obstetricians who were on staff there and spoke with them and said, this is what happened. And lo and behold, this one particular patient, she's like, I do not want to see that doctor when I go in for labor. He cannot, you know, and she ended up getting induced. And then there were no beds on labor and delivery because it was so busy. And then finally it was him when he was delivering her baby. And he turned his act around. She said he was great. And he remembered he had gotten feedback from me and the other physician on staff with him who I spoke with. So I do think that, you know, if you do it in the right way, that, you know, small structural changes and changes in behavior can be implemented.
Thank you. And for the sake of time, we'll try to get through some of the other questions. And so we have one that says, as someone who has experienced infertility challenges and faced intense emotions like anger, disappointment, and even moments of shaken faith, what advice would you share with other women going through similar struggles? And how can they safeguard their mental and emotional well-being during that journey? So have someone who wants to tackle that question.
I'll speak from a doula's perspective because I do support and specialize in fertility doula support. My recommendation is, depending on where you are, whether that's still continuing to navigate the fertility options that are available or whether it's in your day-to-day, is definitely finding a safe space to where you can start to delve into those emotions, those triggers. But I think it really depends on where are you? Meaning, I have some moms that are in the process of going through IVF and it's multiple loss, but they're still, you know, on the journey. And then we're having a moment where a friend is now pregnant. And so showing up and being happy at the same time, but then you're struggling with something that you've been struggling to do. So I think it's finding someone safe that you can share transparently and not always put a face of I'm happy, because it doesn't mean you're not happy for others, but definitely understand that sort of internal parallel space that you're in. But I think it really depends on, when safeguarding those emotions and those feels, the support or the safe space to share those thoughts and those emotions, I think are dependent upon where you are in that journey. If it is pausing on the journey, if it's in the midst of attempting again, or it really depends. But I think it really requires you to find a safe space to be able to talk through those emotions with an unbiased, objective, safe space, non-judgmental.
Thank you. And sorry. So we have two more. So one says, thank you to the panelists for your expertise and insight. Yesterday, the North Carolina governor and the North Carolina Legislative Black Caucus recognized Black Maternal Health Week, an important step, especially as disparities persist. Moments like this feel like some progress. How do we ensure that these efforts translate into sustained momentum and meaningful accountability moving forward, not just for a week of awareness, but as a sustained, consistent year-round priority? Anyone can take it.
I would say vote.
I don't want to dominate, but in addition to voting, I will say there are a lot of collectives, there are a lot of collaboratives that are continuing to look at policy throughout the entire year. So not just, to your point, just focusing on Black maternal mortality, week and celebrating it now, but looking for opportunities throughout the year before, where there are policy and momentum things that are happening. But to Dr. Griffin's point, voting and knowing who are your policy leaders and your politicians that align with addressing these issues. I'm not going to do a political call out, but I will say Congresswoman Alma Adams is our own Charlotte senator that is the spearhead in the Black Women's Caucus, in the Black Mamabis. And so for her to be here in our state pushing for legislative and policy, there are other works and grassroots that are working on some of these very items. And with politics, sometimes those things take time, but everybody should jump in and help with those things.
And lastly, how do you start the conversation with someone you may be concerned about without it coming off as projecting if you know the signs because you've experienced it?
I think kind of starting out by sharing your experience, starting from that place and just kind of expressing your concerns, but remaining curious, not saying, I know this is what you're going through, but just kind of being curious about their experiencing and letting them know what they're experiencing and letting them know what you are experiencing as well can kind of open that door and create some space for them to share. And sometimes it could also mean just passing along some resources. I heard this great podcast. Here's a link. This is a TikTok I saw on this, so sometimes that can open the door too for conversation.
All right. Well, thank you all so much for this conversation. Very meaningful, very powerful. I am now going to pass it to our Madam President for our closing. Is she there? Should I? Yeah. If not, I'll close this out. So we just want to thank you all for your honesty and expertise. These conversations really do matter because Black maternal health is not just about surviving, it's about the dignity, joy, and safety of being heard. And now I see her beautiful face, so now I am going to pass it on.
Sarah, thank you so very much. I apologize. I was trying to come off mute, but thank you to our panelists for sharing your expertise, your lived experiences, these powerful insights, and to all of you that have joined us this evening. Your presence, your engagement, on this critical conversation is helping to move us closer to awareness and advocacy. And so we thank you. We thank you to our Program Planning and Development Committee. We are so grateful for you and your insight on bringing this to our membership as well as those in our community. Again, thank you so very much and have a wonderful, wonderful evening, everyone.
Will you work like me to lift the conversation higher?